Folks, welcome to the heart. A lot of this is anatomy. In this particular lecture of the heart, 20-1 is mostly anatomy. I will talk about a few things, even though you're going to get it in lab. It's worth maybe hearing it twice and just thinking about it while you're listening to the lecture. So, first of all, we have two main circuits or systems that the heart pumps. First, it pumps into a pulmonary circuit, and that's sending the blood to the lungs. And second, it pumps through a systemic circuit, and that's sending the blood to the rest of the body. And the pulmonary circuit is pumped by the right side of the heart. Here's the right atrium and the right ventricle, and that pumps blood to the lungs. Lungs returns to the heart, to the left atrium, and then the left ventricle pumps blood to all parts of the body, the systemic circuit. So the right part of the heart pumps blood to, by the way, why do I circle capillary beds? Because that's where gas exchange and nutrient exchange occurs. Everything else in between is just plumbing. It's just the piping getting it there. Now I say that kind of, I don't want to be misleading. Arteries and veins are very important, and there's diseases of arteries and veins. So we do want to talk about them, and I don't want you to just dismiss them as just plumbing. But in one sense, that's all they are, is plumbing, and capillaries is where the meat of what needs to happen is going to happen, and that is gas and nutrient exchange. All right, so pulmonary and systemic circuit.
The cardiovascular system is divided into systemic and pulmonary parts. The systemic circulation carries blood from the heart to tissues of the body and then returns it to the heart. Oxygen-rich blood is pumped from the left ventricle into the ascending aorta. The aorta then makes an inverted U-turn to form the aortic arch, which gives rise to branches that supply the head, neck, and upper limbs. The aorta continues posterior to the heart as the descending aorta, which travels through the thoracic and abdominal pelvic cavities. It supplies the organs of these cavities and the lower limbs. In the systemic capillaries, oxygen is exchanged for carbon dioxide, resulting in oxygen-poor blood. The oxygen-poor blood enters the right atrium via the superior and inferior venae cavae. The pulmonary circulation carries blood from the heart to the lungs for gas exchange and then returns it to the heart. Oxygen-poor blood is pumped from the right ventricle into the pulmonary trunk. The large pulmonary trunk divides into the right and left pulmonary arteries. These arteries transport blood to the right and left lungs. In pulmonary capillaries, carbon dioxide is exchanged for oxygen. This results in oxygen-rich blood that then flows through the 4 pulmonary veins and enters the left atrium.
All right, there's your circulation, folks. Now, the heart's surrounded by a serous membrane, and you've done this before, so this is second nature to you, maybe, or let me just remind you what a serous membrane is. A serous membrane is a membrane that secretes a serous fluid, a thin, watery solution called serous fluid, into a space or a potential space, because it's not really a true space. It has only serous fluid in it, and is not an open cavernous space. And that serous space is often called a cavity. Now we have, it's like sticking your fist into a balloon. So if this was the heart or the lungs or the viscera, you would have a visceral serous membrane touching the fist or the heart or the lungs or the viscera, and not really a fist, as you know, this is just fist as an example. And you have a parietal serous membrane that's not touching the heart or the lungs or the viscera. And then the cavity is here, but it's just a potential cavity. It's not a true cavity. There's serous fluid in it. Around the heart, we have this visceral pericardium touching the heart. Say the fist is a heart. And we have this parietal pericardium not touching the heart. So this serous membrane surrounds the heart, and it's called the pericardial membrane. And there's diseases of the pericardial membrane, so you have to understand this, because you could have exudates in the cavity. That's abnormal secretions. Could lead to cardiac tamponade. You could have inflammation of the serous membranes, which would be pericarditis. You can have different problems here. So it's important you understand the anatomy of the serous membrane surrounding the heart. This is another picture of the serous membrane surrounding the heart. And the two of them together. So visceral and parietal pericardium, pericardial membrane. This is the location of the heart inside the chest. It's generally centralized, that leans slightly to the left. And what do I mean by that? Well, look at the sternum. The sternum is central. Heart is in the center. Yep, sure is. But more of it's to the left than to the right. And that's because it leans to the left. The apex of the heart, the tip of it, is between rib 4 and rib 5. It's just under rib 4, in fact. You can see that right here. You can see the apex right there. So this is the location of the heart in the thoracic cavity, and very important for where you place your stethoscope for auscultations, where you place your fingers for palpations, and place EKG leads and things like that. So it's very important to understand the location of the heart inside the chest cavity. This is heart tissue we're going to talk about. We're going to talk about intercalated discs. Probably the most important part we're going to talk about are these intercalated discs. But before we get to that, look at the gross musculature of the heart. Look at the fibers. Look how they're running different directions. So I got some going horizontal, I got some going obliquely, I got some going vertical. And what that is when the heart beats, it twists. Almost like wringing out a sponge with two hands. And this allows the heart to push out more of the blood that's inside of it. Just like if you were to take a sponge and put two hands on it and just simply squeeze, you would get water out of that sponge, assuming the sponge is saturated with water. Take the same sponge and saturate it with water again, and this time squeeze but twist. And if you squeeze and twist, you'll get more water out of it. And that's how the heart beats. It has a twisting motion to its beat, which increases the ejection fraction. And what do I mean ejection fraction? Well, we'll get to it, but I might as well tell you right now. You have X amount of blood in your heart. Let's say you have 100 milliliters of blood in your heart, ready to be pumped out, and you only pump out 80 milliliters of it. Well, did you eject 100%? Nope, I did not eject 100%. Ejecting 100% would have been pumping 100 mils. So your ejection fraction is 80 over 100, or 80%. So with this twisting motion, my ejection fraction improves or increases. This is a blown up picture of the heart tissue right here. You have gap junctions. You can see gap junctions right here where things from one cell can go to the other through these gap junctions. And we have desmosomes that are holding the cells together, spot welds holding the cells together. So we have desmosomes and gap junctions connecting adjacent cells. You can see, and these cell junctions are inside things called intercalated discs, and you can see these intercalated discs here. All right, so you can see the intercalated discs. And we'll show you these in lab. So that's the biggest difference between cardiomyocytes, histologically anyway, between cardiomyocytes and skeletal myofibers, is just they're striated, and you have the A bands and I bands like you learned before. But cardiac muscle has intercalated discs that you can see histologically, whereas skeletal muscle fibers do not. This is a table comparing the two, and I'll let you go ahead and read it and take some notes on it. And some of it will be pretty straightforward, but I want to point one thing out. Cardiac muscle only does aerobic respiration. That's it. Now, skeletal muscle primarily does aerobic respiration, but remember, it does have the capability of doing anaerobic metabolism for a little while, making lactic acid, but it can still do it for a little while. Heart can't. Therefore, if you shut down the flow of blood to the heart and deprive it of oxygen, its response is to stop beating. Not to keep beating and go into an anaerobic metabolism, but to stop beating. And this is why when you occlude coronary arteries, you get myocardial infarctions or heart attacks, because they can't do anaerobic respiration, anaerobic metabolism, I should say.
The heart is a muscular pump with 4 chambers, 2 thin-walled atria and 2 thick-walled ventricles. The atria collect blood returning to the heart, whereas the ventricles pump blood from the heart. Oxygen-poor blood enters the right atrium through the superior and inferior vena cavae. The superior vena cava collects venous blood from the head, neck, upper limbs, and thorax. The inferior vena cava collects venous blood from the abdomen, pelvis, and lower limbs. Venous blood from the heart itself enters the right atrium from the coronary sinus. Contraction of the right atrium forces blood through the right atrioventricular valve, also known as the tricuspid valve, and into the right ventricle. Right ventricular contraction then propels the oxygen-poor blood through the pulmonary or semilunar valve and into the pulmonary trunk. The pulmonary trunk divides into a right and left pulmonary artery, which carry oxygen-poor blood to their respective lung for gas exchange. These are the only arteries that carry oxygen-poor blood. Oxygen-rich blood returns from the lungs through the 4 pulmonary veins to the left atrium. These are the only veins that carry oxygen-rich blood. Contraction of the left atrium forces blood through the left atrioventricular valve, also known as the bicuspid or mitral valve, and into the left ventricle. Left ventricular contraction propels the oxygen-rich blood through the aortic or semilunar valve and into the aorta for distribution to the body.
All right, this picture shows you exactly what the video just showed. I'm just going to point out a couple additional things. The 2 things I want to point out first are this fossa ovalis and ligamentum arteriosus. The ligamentum arteriosus used to be called ductus arteriosus, and that was when it was open. It was an open canal or channel when you were a fetus. And the fossa ovalis used to be called the foramen ovale, and that used to be open, and used to connect the left and right atrium together. So blood used to flow from the right atrium into the left atrium, and blood used to flow from the pulmonary trunk into the aorta. So these used to be open when you were a fetus. And the reason why we have them, by the way, you're born and we're born and they close. The foramen ovale closes into the fossa ovalis, and the ductus arteriosus closes into the ligamentum arteriosum. So we had them as fetuses to bypass the lungs. Why pump blood to the lungs when you're not breathing? You're getting your oxygen from your mom at the placenta. So there's no sense in pumping blood to the lungs. You're not going to pick up any oxygen there. You're not going to give up any CO2 there. So we don't pump blood to the lungs. We bypass the lungs through these structures, the foramen ovale and the ductus arteriosus. When you're born, these structures close, hopefully. There are diseases where you're born and they fail to close. And like one of those diseases is called patent ductus arteriosus. That's not good. It's not. I mean, it's good when you're a fetus. PDA, patent ductus arteriosus. It means that your ductus arteriosus stays open after you're born. It doesn't become the ligamentum arteriosum. That means that you're now walking around mixing oxygenated and deoxygenated blood, and that's not efficient. So there are some diseases of the foramen ovale and ductus arteriosus not closing correctly. And the last thing I want to tell you, in the rest you'll get in lab, is about these chordae tendineae. When the ventricles contract, the reason why the blood doesn't go back up into the atria backwards, and it's forced to go into the pulmonary trunk or the aorta, depending on which ventricle you're coming from, is because these valves close and they prevent backflow. But what's to prevent the valves from inverting? Not only closing, but closing and then inverting the other way. And the answer is these chordae tendineae. These prevent the valves from inverting under high pressure. And when I say high pressure, it's relatively high pressure. The right ventricle pressure of the right ventricle is about 50 over 25, 50 systolic, 25 diastolic. And the left ventricle is 120 over 80. That's the one you probably know. So you can see the right ventricle is not under as high a pressure as the left ventricle. But there's still quite a bit of pressure in there. 50 millimeters of mercury is quite a bit of pressure. And those chordae tendineae keep the valves from inverting. All right, so this is a cross section of the heart showing you the muscles. It's showing you that the left ventricle has really thick muscles, and it's showing you that the right ventricle has real thin muscles. That's what it's showing you here. This is showing you the valves. We have the atrioventricular valves that are open here. We have the right AV valves and left AV valves. We have the semilunar valves here and here. We have the aortic semilunar valve and the pulmonary semilunar valve. They're closed. And they do go back and forth like that. I mean, there are points and times when they're all closed. But when the AV valves are open, blood is flowing from the atria to the ventricles. And then when the ventricles start to contract, they close the AV valves and open the semilunar valves. So when the AV valves are closed, the semilunar valves are open. And in fact, what you hear for heart sounds, what we call a lub-dup heartbeat, is actually the valves closing. The lub is the AV valves closing, and the dup is the semilunar valves closing. These semilunar valves right here. So that's what you hear with the heart beating is closing of the valves, the atrioventricular or the semilunars. Okay. This is just showing you blood flow to the heart. I'm not going to go through it all here because you'll learn it in lab. But I do want to show you one thing. The heart, it's very important that the heart feed itself, give itself oxygen, give itself nutrients. And it's so important that the very first two branches off the aorta are coronary arteries. And you can see the left coronary artery and right coronary artery right here. And rising off these coronary arteries will be all the arterial branches that take oxygen to the heart's cardiomyocytes. And we will learn these blood vessels. This is showing you the venous drainage. After you hit the capillaries, all the venous blood starts returning back to the right atrium. And before it gets to the right atrium, it gets all into this coronary sinus. The coronary sinus has its own opening into the right atrium. So the venous drainage of the heart blood ultimately comes back to this coronary sinus, which goes into the right atrium. And we'll learn these blood vessels in lab. This is showing you a normal artery, and it has a tunica intima, tunica media, and tunica adventitia. Tunica intima, tunica media, tunica adventitia. You'll learn that in lab. And you can see cross-section of it right here. And you can see the tunica intima, tunica media, and tunica adventitia. And then this is showing you occlusion. Now, lots of things can lead to these occlusions. These atheromas or occlusions, they can have fat in them, fat and cholesterol. They can have platelets in them. They can actually be calcified. They're not bone, but they're calcified. They're hard with calcium. They can you can bleed into them. They can have old dried up blood inside them because the blood is forced across the wall. And a couple dangers of these atheromas. First of all, it leads to atherosclerosis. All right, and the couple dangers is this. First of all, one danger is that a piece of this could break off and become an embolism. That's one danger. It breaks off, becomes an embolism, and clogs up an artery someplace else, like in your brain, and that's a stroke. The other danger is you completely occlude this artery. If this atheroma or plaque keeps getting bigger and bigger and bigger, and pretty soon you occlude this artery, you are not going to deliver any oxygen distal to that occlusion. And you can have tissue necrosis, tissue death, for not delivering oxygen and nutrients to the tissues distal to the atheroma. So this is why we check blood pressure and cholesterol levels, because the correlation is high blood pressure and high cholesterol hastens the development of these atheromas, whereas low blood pressure and low cholesterol seems to be linked to the lack of these atheromas, or at least the very slow growth of them. This is showing you one of those atheromas. Whoops, sorry. This is showing you one of those atheromas occluding a coronary artery, and of course, if it occludes it completely and no blood gets past here, this big part of the heart dies because it didn't get any oxygen for a period of time, and you had a heart attack, and that's dead muscle tissue now. So that's the danger of these occlusions: heart attacks, AMIs, acute myocardial infarctions, or sometimes just myocardial infarction, and strokes. If it was in the brain, it would be called a stroke. Cerebral ischemic attack. Cerebral ischemic attack. Sometimes called a transient ischemic attack. It's mini stroke. All right, so that's that. Now here, this is things that we use. Risk factors for coronary artery disease, by the way. CAD stands for coronary artery disease. Myocardial infarction is a heart attack. So here's some risk factors. Smoking's a risk factor. High blood pressure, diabetes. Having diabetes is a risk factor for this. Obesity is a risk factor. Sedentary lifestyle is a risk factor. Probably you know all of these. And then down here are listed some treatments and some drug treatments, some surgical interventions like stents and balloon angioplasty. And of course, I'm not going to a lot of this because you're going to be experts at these things as you get into your life, your life as a healthcare worker. All right, that's it. See you in the next section.